Okay, so I think we can start. Again, dear audience, welcome. I'm Mariangela Pellegrini. I work for the ERN-EuroBloodNet, so the European Reference Network on Rare Hematological Disease. And I'm really pleased to welcome to the 6th webinar of the topic on focus from Willebrand disease for patients, organization, and healthcare professional that is coordinated by the ERN and by the European Haemophilia Consortium, the umbrella patients organization. And this program indeed has it's really a co-joint program because it has been created in partnership with EURORDIS-Rare Diseases Europe, and also it has been supported by members of the scientific committee like Professor Sophie Susen from the CHU de Lille in France, Jeroen Eikenboom in the Leiden University Medical Center in Netherlands, Flora Peyvandi from Ospedale Maggiore Policlinico in Italy. So I'm honored to pass the floor to Daria, who will explain the aim and present also the European Haemophilia Consortium. Thank you, Daria.
Thank you so much. Thank you, Mariangela. First of all, just a few words about the European Haemophilia Consortium. And of course, I need to introduce myself. I'm Daria Camilli, Education and Communication Manager at the European Haemophilia Consortium and also Support Manager for the European Haemophilia Consortium von Willebrand Disease Committee. EHC is an international non-profit organization representing 48 national patients' organizations for people with rare bleeding disorders from 27 member states of the European Union and most member states of the Council of Europe. We represent approximately 90,000 people diagnosed with rare bleeding conditions such as hemophilia, von Willebrand disease, and other rare bleeding disorders across Europe. Among those, VWD is the most common bleeding disorder, affecting up to 1% of the general population. However, it is often neglected and overshadowed by hemophilia. And because of this, we decided to create this program together with the ERM with the aim to distinguish von Willebrand disease from hemophilia and focus on the particularities of this bleeding disorder. In the framework of this program, we will discuss very topical areas related to VWD among patients and healthcare professionals and give visibility to the challenges of those living with this rare disease, including quality of life, access to treatment and care, medical services available in Europe, diagnosis and treatment options, and of course, the overall patient journey through life. As I said, it's the whole program, and every month we have a webinar, and this one is the 6th already. And today's webinar named Do Not Let People Bleed Their Way to Treatment, Accurately Diagnosing VWD. We devote, of course, to diagnosis. Despite being considered the most common inherited bleeding disorder, VWD, in fact, may also be the most difficult to diagnose, and we're going to discuss all this today. I pass the floor back to Mariangela to talk about the home rules and some other interesting parts of this program.
Thank you so much, Daria. So indeed, we have some home rules. The first one is that, as you can see, your microphone is muted and will be muted along all the presentation. But at the end of the presentation, so as you may know, today we have 3 speakers. So at the end of the 3 speeches, there will be the Q&A session. So you will have the possibility of comment, share feedbacks, or raise questions. And you can both write your comment or questions in the chat during the presentation, or if you feel more comfortable in taking the floor and speak orally, you can raise your hand and we will unmute you for taking the floor. Then also this program is accredited by the European Body of Accreditation in Hematology. And so one session is 1 credit. If you participate to the full program, will be 13 credits of continuing medical education point. Forgetting that is really simple. You just need to participate and to register to the program. And it is very important to do this step additionally, because at the end of the program, you will receive a survey. is a satisfaction survey. Is very quick. It's only 3 questions. But please answer them, because it's also a way for us for tracking your presence, and not just during the webinar, but also in the satisfaction assessment after, if you want to get the credits, and we will share with you the instruction for getting the credits. So don't worry, you will hear from us. So now we arrive finally to the lecture. I have the pleasure to introduce to you Dr. Sophie Shapiro, that he's a consultant hematologist and associate professor at Oxford University, and she works entirely in the field of hemostasis and thrombosis, hemophilia and other bleeding disorder, thrombosis and anticoagulation.
And for today's webinar, we have a duo of patient representatives. And it's my great pleasure to introduce to you Joe Traunter, EHC von Willebrand Disease Committee co-chair, and George Korosidou from the Greek Haemophilia Society, member of the board. And with this, I pass the floor to Joe.
Thank you, Daria. So as you both so eloquently introduced us, my name's Joe Traunter. I'm one of the co-chairs of the EHC VWD, and I'm delighted to be here to discuss this really critical issue of diagnosing von Willebrand disease before it leads to those significant or even catastrophic bleeds. So I suppose today our question really remains focused on why do so many patients with von Willebrand disease just manage to stay undiagnosed until they have these severe bleeding episodes? And the answer lies in different factors, in several factors. So really we need to really focus on this in order to improve those patient outcomes by early diagnosis and not wait until we get those bleeds. So myself, I've got von Willebrand disease type 2M. I've also got 2 children with von Willebrand disease, and I myself wasn't diagnosed until I was 37. And that wasn't because I didn't visit my doctor regularly with significant bleeding episodes, because I did. And twice as a child, my GP did send me to the hospital for tests to understand why I was bleeding, but for some reason, a diagnosis just wasn't reached. So it was only when I got into my early 20s that very scary bleeding episodes happened. And that was connected to childbirth. And that did make the clinicians notice that there was an issue, but I still didn't get that diagnosis. And it was only at the age of 37 and on baby number 3 that the doctors decided that they really couldn't risk another birth without a diagnosis. So I was referred to a hematologist. Sorry, I'll ignore that. Sorry. Yes, so I was referred to a hematologist, and they immediately diagnosed my VWD, and that diagnosis saved my life. And even then, I still spent 2 weeks in intensive care. So you can imagine that scenario if I hadn't been lucky enough to receive the diagnosis and subsequent treatment. And mine isn't an unusual story. If there's not already a diagnosis in the family, it's actually incredibly difficult to find a doctor who A, recognises the condition, and B, really understands the implications of the condition. So many people I speak to have a similar story. Like mine, they maybe have a traumatic bleeding incident that eventually ensured that clinicians did take notice. But is that where we want to be in order to gain that diagnosis? And why is that happening? We know that von Willebrand disease can be a silent condition for many individuals. The symptoms like easy bruising, frequent nosebleeds, heavy periods, that's often considered by doctors to be, quite benign issues. And as a result, both patients and clinicians might overlook these conditions and not really realise that there is potentially a serious underlying disorder there. Secondly, there's a lack of awareness and understanding about von Willebrand disease, particularly amongst healthcare workers. And unlike more well-known disorders like haemophilia, for instance, von Willebrand disease doesn't always present with those dramatic symptoms until maybe some kind of injury or surgery takes place. And that can lead to that lower index of suspicion, I suppose, when parents present with that mild or non-specific bleeding symptoms. So really, education and awareness are really crucial in bridging this gap, and events like this are just so important. Additionally, the symptoms of VWD can vary greatly between individuals, and that makes it really challenging to diagnose. And some patients might, they might only have minor symptoms, while others may have really significant bleeding. And that variability just leads to that misdiagnosis or delays in getting that testing. So, we've just got to be really vigilant, and we have to encourage clinicians to be really vigilant, especially when they've got a patient that's appearing in front of them with those unexplained or unusual bleeding patterns. The other factor which we know is really complex is that the complexity itself of VWD, and that means that it can be quite troublesome ordering the specific blood tests, and they're not routinely blood tests which are available at your general practitioners. And so we may have doctors who are actually hesitating and not actually looking beyond a simple coagulation test. And when they get that coagulation test and it looks okay, they're sort of dismissing it as, yeah, there isn't a problem. And lastly, there's that issue of communication and patient advocacy, I suppose. And patients might not always communicate that full extent of their symptoms, or they might downplay them or even believe that they're normal, because after all, if bleeding is normal in your family, you may just think that's how you're made. And so they don't always communicate just how troublesome it is, and when they've lived with it for so long, they don't even themselves realize what the problems are. So in summary then, sort of that underdiagnosis of VWD really stems from that combination of subtle symptoms, that lack of awareness, complexity in getting a diagnosis, communication. And only if we're sort of addressing those issues can we really get more people coming forward and getting them diagnosed with VWD. So our goal really today is to raise awareness among patients and clinicians. And we want to emphasize the importance of recognizing those signs of von Willebrand disease and to take those proactive steps towards diagnosis and towards treatment, so that, yes, nobody is bleeding their way to treatment. So all that's left for me to do is thank you for your attention. Today we've got Georgia, who'll be talking to you about her patient journey. And then obviously that's going to be followed by Susie Shapiro, who's the consultant hematologist, and she'll discuss with you the clinician's experience. So thank you so much for joining us. It's really important that you're here today, and we really appreciate you taking the time. So over to you, Georgia.
Thank you, Jo. I'm Georgia. I think that all von Willebrand patients have a little bit of a similar journey in our life. So some things you hear the same from me too. I have von Willebrand type 2, and I'm in the board of the Greek Haemophilia Society almost 15 years now in different positions. I was diagnosed at the age of 21 after a very difficult problem with my father, who's also a von Willebrand patient. He went for a very common surgery among men, and he ended up in the intensive care for about 40 days. Then we all got tested in the family, relatives, and 6 people of us have von Willebrand, type 2 and type 1. As a child, I had also many problems, and I went to the hospital many times with bleedings, especially nose and tooth bleedings. And the biggest problem, although, was the first period. I was bleeding for a month, severe bleeding, and I had to be hospitalized, I think about 4 days. My hematocrit has dropped to 17. I was passed out 2 times. And even then, nobody talked us about von Willebrand, and they stopped the bleeding with birth control pills. I was 12 years old. I'm really happy that the last years I hear how you can count your period, because it's something that really nobody talks about. You can't tell to your friend, hey, how much do you bleed? It's not an issue that we discuss it. But last year, a few years now, we say that you have to change more than 5-6 times a day. This is a bleeding. This is very important because we can measure that. I realized after I gave birth to my son, that I was bleeding all my life during the period until I gave birth, until the pregnancy. I didn't know that, and okay, my exams was not always very good. I have anemia all my life, but nobody said anything that I should do something, prophylaxis or anything. And I didn't know how to ask it. And I didn't even know that I was bleeding. I didn't know how the period should be. After my pregnancy, things got better, and I now realize how I should have been in all my life. Anyway, it's very nice that now we can count it at some point. Another, well, okay, let me say something more about that. Can realize that that the impact that this can have in somebody's life. Likely I work in an office, but if I wanted to work in another industry that I have to be more active or standing more, that would be possible. I have to take 5 days a month leave from my work because I wouldn't be able to do anything else. Another very important issue is the bruises. I still have many bruises every day in my body. Most of them, I don't know how they happened. And the most important thing about that was when I was a child, the first days at school, the principal called my father, my parents, and told them that if we didn't know your family from the older child, I have an older brother, we had called social services. It's not normal for a kid, and especially a girl, to have so many bruises. You imagine how that would have gone. It would be terrible for the parents and for me also. They won't be do something else. Von Willebrand can be very easy at some point if you know about it, but the impact of this disease can be catastrophic many times if you don't know about it. And physicians must know and must tell the patients, we are the patients, we don't know how many diseases there are in the world. We need the help of our doctors and then the right directions from them for the bleedings, for the exams that sometimes have anemia. It's not that take a pill for iron or something. We must be better in giving the right, I don't know how else to say it, the right directions, do something more about it. That's all for me. Thank you.
Thank you, Georgia and Joe. Let me just find my slides and then. Great. So hi. So as I was introduced, I'm Susie Shapiro. I'm a consultant hematologist and I'm based in Oxford in the UK. These are my disclosures. So what we had hoped to go through today was the impact of the lack of diagnosis, which I think Joe and Georgia have very eloquently covered. And so thank you very much for starting us off. I'm then going to talk mainly about the pathway to diagnosis and then talk about some of the consequences of an incorrect diagnosis. So getting an accurate and timely diagnosis, as you have already heard from Joe and Georgia, much better than the slide, is a major challenge. So it's well reported that you can have delays of more than 15 years from the onset of bleeding symptoms to a VWD diagnosis. And clearly in Joe's case, it was much longer than that. There remains confusion about the types and the subtypes of von Willebrand's disease and how to make that distinction and the importance of making that distinction. And some of the barriers to an accurate diagnosis involve the understanding of the difference between what's normal and what's abnormal bleeding, and then the lack of clarity around making the diagnosis, as well as, unfortunately, the limited availability and the expertise of specialized laboratory testing. But we hope today to break down some of those barriers, at least the first couple. So what is the pathway to diagnosis? Ultimately, to begin with, there has to be a recognition of symptoms, and that is generally twofold. So as an individual, recognizing that they are bleeding more than other people appear to be bleeding and more than they might expect, and then awareness of the first person that they see within the clinical environment. So here I've said primary care awareness, but it could be if you go to hospital and you're seeing a general doctor, that they need to be aware in order to refer you to the hematologist. You then need to be referred to a specialist centre, and it will work differently in different countries. In the UK, haematology would be the first part of that referral, but actually many haematologists will then need to refer you to a specialist haematologist, so a haematologist specializing in bleeding disorders, in order to get the blood test done and that diagnosis. So there are several steps along the way where the condition has to be recognized before you'll get an accurate diagnosis. So what about the symptoms of von Willebrand's disease? We've touched a bit upon them already, but I guess importantly, the symptoms depend on the severity of von Willebrand's disease and how severe those symptoms are within that. Classically, it's described mucocutaneous bleeding. So that's nosebleeds, heavy menstrual bleeding, easy bruising, prolonged bleeding from minor wounds and also from the mouth, and gastrointestinal bleeding, so bleeding from the guts. Bleeding after procedures, so if you have dental work or surgery, and also bleeding after childbirth. You can get musculoskeletal bleeding, so bleeding into the joints and muscles, but this is generally in the most severe types of von Willebrand's disease and not in the less severe types. So how does one as an individual recognize that the bleeding is abnormal? Because often I will meet someone who has horrendous periods, but actually their mother's had horrendous periods and her mother before that has had horrendous periods, and it's sometimes felt that that is normal for that family because you may be more likely to speak to your mum about these things than your friends. Paula James, who is a haematologist in Canada, has a Let's Talk Period website and program, and within that they've designed something called a BAT score, which is a self-bleeding assessment tool score. So they have validated it, and it's for a person to complete. It's an online tool, and it can help you better understand whether any bleeding you're having currently or any previous bleeding might be normal or abnormal. This self-bleeding assessment tool is very similar to what we use clinically, which I'll go through in more detail later. So you'll have more of an idea of what it's likely to ask you online. But I did it the other day just to see what it would be like. And you just answered questions about lots of different types of bleeding, and it gives you a score at the end, and it says whether it's within the expected normal range or not. There is understandably a disclaimer that it doesn't constitute medical advice. And so if following doing it, you have concerns about bleeding, then please do see a medical practitioner. But I think one of the advantages of it is that you can score yourself, and then you can print out the score, and you can take that to your initial medical practitioner and say, actually, I'm having all of these bleedings. My score is higher than normal, please refer. And so it may be a helpful additional nudge for the first general practitioner that you see to refer you to a specialist. So then this slide's about assessment in primary care. So really assessment by the first general medical practitioner that someone sees. So from their point of view, someone's coming to see them with bruising or bleeding, and they need to consider trauma, whether it's accidental bruising or non-accidental bruising, someone has been injured, particularly a child. And also consider medications as a cause. So I've listed a whole load of medications on the right-hand side. Exactly which ones they are may not be necessarily important for all of this audience, but it's mainly to say sometimes people are given anticoagulants or blood thinners, which can increase the risk of bleeding and bruising. Also, in your body, you have platelets, which are small fragments of cells which are quite sticky in themselves. And when you cut them yourself, they form the initial plug. And then the glue in your blood, including from Willebrand disease, makes that plug much firmer. So if you're taking something such as aspirin, it makes the platelets less sticky and it increases the risk of bleeding and bruising. There are other drugs that can cause low platelets, so reduce the platelet count in your body, which again can cause bruising and bleeding. And steroids tend to affect the collagen in your blood and skin elasticity and also affect bruising. So those are common causes. On the left-hand side, the practitioner also needs to think about the pattern of bruising. So is it in unprotected areas? So what I mean about that is it in the arms and legs, particularly distally, because it's so common to kind of hit your arm, at least gently. It's quite common in the normal population to have bruising on arms and legs. It's much less common to have bruising on the body, on the face, because those areas are generally protected. And they'll need to ask and think about any other bleeding, such as nosebleeds, heavy menstrual bleeding, and also whether there's a family history. And what will probably be going through their mind are common causes of bleeding and bruising. So medications, senile purpura is just increasing likelihood of bruising as we get older. Alcohol and liver disease increase the risk of bruising, and also vitamin C deficiency or vitamin K deficiency. Much less common in general is von Willebrand disease or haemophilia, and I've listed some other much rarer conditions, and they're of course really important to recognize as a possibility and try and exclude. So a key way of doing that in general practice as that first general practitioner is to consider doing a bleeding assessment tool. So these are recommended in primary care. It's a little bit different by the time someone sees a hematologist or comes to see me. As in primary care, they're recommended as a screening tool and to help guide further diagnosis. By the time someone has managed to make it to me, then actually I should just be getting on and doing the von Willebrand disease screen because the risk is that much higher. However, I may use the bleeding assessment tool score in a different way to get an idea of the breadth and the severity of bleeding. But in my environment, I'm not using it as a rule in or rule out for additional blood testing. I'm hoping that makes sense. So what is this bleeding assessment tool? So this is the ISTH, the International Society of Thrombosis and Hematology, is the bleeding tool. I haven't quite done it all, but there are 2 pages of this. But I hope by taking it through you, it gives you an idea of the kind of range of symptoms and the way that we try and have an idea of how severe it is. So the symptoms are on the left-hand side, and then going horizontally, the symptoms gradually get more severe, and you score 0 in the first column all the way up to 4 in the column on the right. So for epistaxis, which is nosebleeds, if you don't have them or they're trivial, you score 1. If you have more than 5 a year or they last for more than 10 minutes, then you score 1. If you've got as far as going to a general practitioner for a consultation about your nosebleeds, but nothing further has happened, then you score 2. If you have required packing or cauterization, then you score 3. And if you have needed blood transfusion or other replacements therapy, then you score 4. For cutaneous skin bruising, again, it goes from whether you have 5 or more bruises that are relatively small and flat and in exposed areas to them being extensive and as far as a spontaneous hematoma requiring blood transfusion. And bleeding from minor wounds, again, whether you don't really get it or whether you have more than 5 a year, whether the bleeding lasts for more than 10 minutes, whether you've got as far as just having a consultation or whether you've had to have surgery to stop the bleeding and or on the far right, blood transfusion or replacement therapy. So there's similar things for bleeding from the oral cavity or from the gut. And then on this next page, so tooth extraction. So tooth extraction is actually a really good challenge for your blood clotting system. So that can be quite useful if people have had teeth extracted for helping get an idea clinically of someone's bleeding risk. So you score whether or not you've had bleeding in more or less than 25% of procedures, or if you've had to go back and had another stitch or packing, you score 3. If you've needed blood transfusion replacement, you score 4. Something similar for surgery. For heavy periods, you can see the score is quite old. It talks about changing pads more frequently than every 2 hours, whereas clearly there are many more sanitary products available now. But also it talks about time off school or work more than twice a year, whether you've been started on hormonal therapy or an antifibrinolytic such as tranexamic acid, whether it's been present since menarche when your period started, and whether you've had to come into hospital for it. And again, postpartum hemorrhage. So someone should be asking all of those questions, or the self-bleeding assessment tool score takes you through quite similar questions. And there are also a few more questions that I haven't gone through around bleeding into muscles and joints. But for children, a score of 3 or more is abnormal. For adult males, a score of 4 or more is abnormal. And I should just say the self-bleeding assessment tool score, although it's under the website Let's Talk Periods, it is for both men and women. I meant to say that earlier. For adult females, a score of 6 or more is normal. What I would say is that if someone hasn't had many hemostatic challenges, so if they haven't had teeth taken out or if they haven't had surgery, it can be really difficult to be confident at that score if they're scoring low. It can be sometimes difficult just based on the score to be reassured that they don't have a bleeding disorder. So what do I think should precipitate referral to a specialist centre? So the bleeding history is crucial. A bleeding assessment tool score more than the normal limit should be a clear-cut referral to a specialist centre. But within that, abnormal bleeding and someone with few hemostatic challenges is also a reasonable reason, in my opinion, to refer someone to a specialist centre. So if you do the score, someone may not score high, but they may never have had teeth taken out, they might not have had surgery. And if you think they score highly in 1 or 2 areas, then please do refer. I would much rather someone was referred than not, if there was any doubt. And also if there's a family history of bleeding disorder, then someone should just be referred. So I've got 2 kind of example presentations to take you through how that might work. So we have a 24-year-old woman. She presents to a general practitioner with a several-year history of easy bruising. She has no other history of bleeding, and particularly she has had adult teeth out without bleeding, and she doesn't have heavy menstrual bleeding. She's on the combined oral contraceptive pill, but that's for contraceptive purposes. She didn't have it started for heavy menstrual bleeding. She does take occasional ibuprofen, which is one of the medications that can be associated with the easy bruising. She has an ISTH bleeding assessment tool score of 2, which is within the normal range for an adult woman, and she has no family history of bleeding. So it would be reasonable, based on that, to reassure her. On the other hand, you might have a 24-year-old woman who presents with a several-year history of easy bruising, but with further questions, actually, she bled for 2 days following a tooth extraction, and she's had heavy menstrual bleeding since menarche, since her period's begun. She's also on the combined oral contraceptive pill for contraceptive purposes and taking occasional ibuprofen, but her ISTH BAT score is 6, so it's above the normal range for an adult woman, so she should be referred. And then, having made it to the specialist centre, so that is the most difficult thing, is making it to the specialist centre. But what do we do, or what might you expect would happen in the specialist centre? So first of all, we should again be taking a full clinical history, so the full bleeding history, including a bleeding assessment tool score, which gives us an idea of the severity and the type of bleeding. The family history, medications, other medical history, doing a clinical examination, including for bruising, whether someone's hyperflexible, which could be a sign of collagen disorder. And then the tests. So I believe one of the other webinars has gone through the different types of von Willebrand's disease. So I will go through it a little bit, but not in masses of detail. But the tests that should be done by the time you get to a specialist centre are a von Willebrand factor antigen. So that measures the amount of von Willebrand factor that is in the blood. You also need a test for von Willebrand factor activity, and one of the recommended tests is called GP1BM, but that looks at the function of the von Willebrand factor that's in your blood. And you should also have your factor VIII level checked, because von Willebrand factor acts as a carrier for factor VIII in the circulation. So if your von Willebrand factor levels are low, your factor VIII levels will also be low. So if those tests are low, then they should be repeated to check it again, and also on repeat a second von Willebrand factor activity assay. So there's another type of assay for von Willebrand factor collagen binding, for example, should be done. And there are other tests that we can do looking at different types of function on the von Willebrand factor. So there's something called ristocetin-induced platelet aggregation. We can also consider doing von Willebrand factor multimers when we look to see at the pattern of what the von Willebrand factor looks like. It's kind of an image of von Willebrand factor. Genetics, particularly for type 2 von Willebrand's disease and type 3 von Willebrand's disease, is less useful for often in type 1. I'll come back to that on the next slide. And potentially a desmopressin trial. So desmopressin is one of the drugs that can be used as treatment in some forms of von Willebrand's disease. It's generally a subcutaneous injection. It can be given, there is also an intranasal spray when it is available, and it can be given intravenously. But what it does is it releases the body's own stores of factor VIII and von Willebrand factors. So you have a temporary increase in factor VIII and von Willebrand factor that can last for about 6 to 12 hours in people who respond. So although it's a treatment, it can also be used to diagnose type 1C von Willebrand's disease, which is a particular subtype where you get really rapid clearance. And it's important to know if you get really rapid clearance, because it will affect the treatment that will be suitable for the person. This I'm not going to go through in detail, but I took it from one of the recent international guidelines. So ASH-ISTH and NHF-WFH did joint guidelines in 2021 on the diagnosis of von Willebrand's disease. And this is one of the figures from that. For any clinicians on the call, it is a good start for taking you through the pathway and how to partly diagnose von Willebrand's disease initially, but then also to work your way through the different subtypes. So a little bit about the types in relation to why it's important. So type 1 von Willebrand's disease is a quantitative deficiency of von Willebrand factor. So that means that there are lower levels of von Willebrand factor in the blood, but what you have works normally for the level that's there. It is multifactorial. And so genetics are less clear cut, but within that, the more severe forms, so certainly if your levels of von Willebrand factor are less than 30%, we would consider doing genetics. And it's classically an autosomal dominant inheritance, but it tends to be less clear cut than some of the other forms of von Willebrand's disease. So the treatment includes partly targeted treatment for bleeding, so cauterization for nosebleeds, hormonal treatment for heavy menstrual bleeding, tranexamic acid, which if one once forms a clot, makes it harder for the body to break down the clot, and is now used across most bleeding disorders and also in the normal population who are going for surgery. Desmopressin, which I've talked about previously, and then, if needed, replacing the von Willebrand factor and factor VIII, either with recombinant von Willebrand factor and recombinant factor VIII, or with plasma-derived von Willebrand factor concentrates. Type 3 von Willebrand's disease is, again, a quantitative deficiency, but it's severe deficiency, but we can't detect the von Willebrand factor in the blood. And that is autosomal recessive inheritance. You've had to inherit one gene from each parent. The specific treatment there includes tranexamic acid and also von Willebrand factor VIII replacement, which would be considered not only for individual treatments if there is bleeding, but consider for prophylaxis, regular treatments in order to prevent bleeding. What's important here is that desmopressin is not going to be effective because your body doesn't have enough stores of von Willebrand factor and factor VIII to release. And then type 2 von Willebrand's disease. So type 2 von Willebrand's disease is a qualitative deficiency in von Willebrand factor. So the von Willebrand factor that you have functions less well than normal. And the way that we diagnose it is when we do the von Willebrand factor antigen test, which looks at the amount and the quantity that's there, compared to the activity test that looks at the function. The functional activity test is less than 70% the antigen test. So for example, if I do both tests, I might have 100% antigen and 50% activity for a patient. And that would be indicative that they have one of the types of type 2 von Willebrand's disease. Type 2 von Willebrand's disease is autosomal dominant, so you just have to inherit it from one of your parents, except for type 2N, which is a little bit different, but you may have some effect if you've just inherited a gene from one of your parents, but for the most severe type of it, you would have needed to inherit a gene from both of your parents. In type 2 von Willebrand's disease, again, tranexamic, for all of these kind of specific treatments, such as cauterization or hormonal control of periods, is there, but specific treatment from the subtype, again, tranexamic acid will work, and factor VIII von Willebrand factor replacement will work. Desmopressin may be of benefit in some of them, but generally just for minor bleeds. Within the subtypes, there's type 2A, which I haven't gone into details about, but I've just highlighted type 2B here. That is associated with increased binding of the von Willebrand factor to platelets. And in this subtype, desmopressin is contraindicated, because if you give someone desmopressin and it releases the abnormal functioning von Willebrand factor, it can cause someone's platelet counts to reduce and then increase the risk of bleeding because of the reduction in the platelet counts. So it's really important to know whether or not someone has type 2B von Willebrand's disease as to one of the other types, because it affects the treatment. There's type 2M, which Jo mentioned she had, and there's then type 2N. So this one is different to the others. So this one is caused by a specific defect in the factor VIII binding site on von Willebrand factor. And so the factor VIII is no longer protected by von Willebrand factor. So actually your von Willebrand factor levels, the antigen and the activity, the basic activity tests that I've talked about appear normal. But if you do a von Willebrand factor VIII activity binding assay, then it's much reduced. That is not done by many labs at the moment because it's quite complicated, and so it tends to be done infrequently. So actually, the quickest way of diagnosing type 2N at the moment is through genetic testing. One of the importances is that it can be misdiagnosed as haemophilia A, and if it is, then someone will receive the wrong treatment because they would just receive factor VIII replacement or maybe desmopressin, whereas actually they will need von Willebrand factor, probably. The desmopressin might work, but they may well need von Willebrand factor to have normal von Willebrand factor to increase their levels of factor VIII to normal. So what are the consequences of the incorrect diagnosis? Hopefully you will, they will make sense through what I have been discussing in the last couple of slides. So one of the consequences is incorrect treatment through being diagnosed, through either not being diagnosed or being misdiagnosed with haemophilia A or misdiagnosed with your subtype of von Willebrand disease. And so then the treatment may be ineffective, it might even be harmful, and all treatments have side effects. You might have progression of the symptoms. So if you're having recurrent bleeding, then you may remain more anemic. You might be resistant to iron treatment. If you've got very severe von Willebrand disease, so the type 3 von Willebrand disease, then you may have more damage to your joints until the diagnosis is made through joint bleeds or muscle bleeds. You may have excessive bleeding during procedures. You may also then get incorrect genetic counselling, either because the subtype of von Willebrand disease hasn't been recognised or because you've been misdiagnosed with haemophilia or not having a bleeding disorder. And when someone is pregnant, we think both about the mother and her safety, but also the safety of the fetus and what the chances are that the fetus has a bleeding disorder and how severe it is. So again, if there's a misdiagnosis, then there's a risk of incorrect precautions to protect the fetus during the delivery and in their early years. There will be a psychological and emotional impact through loss of trust in healthcare and emotional distress. And there is potentially also a financial burden, either because one is unwell and can't work, or depending which country you're in, because of the costs of the wrong treatment and the correction expenses of that. And so this slide is really of our take-home messages, with the impact of the lack of diagnosis, which Georgia and Joe highlighted to begin with, through the health impact and the psychological and also societal impact. The pathway to diagnosis through the recognition of symptoms, the primary care consultation with the evaluation by a general practitioner, before referral to the specialist and that specialist consultation and advanced tests and laboratory tests. And sorry, this slide is squished together, but the consequences of an incorrect diagnosis, including the incorrect treatment, progression of symptoms, incorrect genetic counselling, psychological emotional impact, and the financial burden. And with that, I will stop screen sharing. Thank you.
Thank you very much for your presentation. So indeed, we have received already some questions in the chat, so I will take the first one. Could von Willebrand people donate blood in your countries? What are the laws in regard to that? My boyfriend has von Willebrand disease and is in Germany. We've come to the conclusion that his plasma and platelet couldn't be used but the P protein red blood cell could be useful to someone, maybe.
Yeah, that's a really good question. So actually, and so within the UK, Joe may have direct experience of this. It's not a question I have been asked for a while. So off the top of my head, what I would say is, in the UK, if you have ever received a blood transfusion or plasma-derived concentrates, then you would not be allowed to give blood. I believe, like, if you have significant bleeding, I think there would be caution on giving blood anyway, because you are likely to have anemia. I believe that if you think that you are borderline and that you have a very mild disorder, then there is a way in the UK for it to have a medical consultation to be considered. But the questioner is quite right that in theory, the red blood cells, the packed red blood cells would be really useful, but the blood transfusion service wouldn't want to use the plasma because that would have less von Willebrand factor VIII than normal, and that probably most transfusion services don't have the way to direct that transfusion. But Joe, if you know particularly about VWD in the UK, then please correct me. No, you're looking it up online. No, I had a quick look. The Haemophilia Society website says if you bruise or bleed easily, then don't donate blood. But I do feel that's something that I should know, so I will try and find out. I don't know, Georgia, do you know about in Greece whether people are allowed to Joe cannot unmute herself.
Okay, I've managed it now. I've been allowed. I think there was a block on it. Yes, I am unable to donate blood or any other blood products because I have had factor-derived concentrates and I have had multiple blood transfusions. My understanding is, speaking to other people, that we're not permitted to donate blood, and that their products, our blood, are not something which can be usefully employed.
Yeah, I think it will be because of the difference in separating from an individual transfusion, not using the plasma compared to the red blood cells. Georgia, is that your experience in Greece as well?
I don't know if there's a law in Greece, but we don't allow to give blood. I don't know if somebody doesn't know that has von Willebrand and give blood, what happens then? How is it checked in the laboratory? And if it's checked.
It won't be checked. So there will be a screening test of medical health conditions, but whether or not you have a bleeding disorder wouldn't be routinely checked because yes, it would be enormously challenging to do it for every donation. So what every donation is tested for are the core viruses, which is crucially important. But yeah, the bleeding disorder would rely on self-declaration.
Also, if the person has not been diagnosed, then it's more likely that that person will not have had any blood products in terms of factor-derived treatments, and they won't have potentially had blood transfusions. And if they had a blood transfusion, they wouldn't be able to donate blood anyway. So I imagine that some of the risk is gone if they are simply donating blood.
Yes, and the person who asked the question dropped a message in the chat saying that she believes it imposes a risk to the blood donor because the needles are slightly bigger, and they could get a hematoma at the venipuncture site.
Yes, and so I think that's why the UK Haemophilia Society say don't donate certainly if you've got bruising, but it wasn't an absolute no on their website. But I wonder if that's because some people who are, for example, carriers of haemophilia may have levels within the normal range. So for them, it would be a bit different. So I wonder if the fact that it's not an absolute no is because of carriers of haemophilia who might have normal levels themselves, rather than people diagnosed with von Willebrand disease and its maybe more mild forms. Yeah.
Could I ask a question, Susie?
Yeah.
So my daughter had her genetics done, and when the genetics came back, it did say that she had the genetic markers for both type 1 and type 2M. How's that possible?
Yeah. So genetics is sometimes useful, but it's not always useful. So I don't know if you remember, did she just have one gene mutation? So It's fine. So the von Willebrand factor gene, everyone has two genes for it. One she will have inherited from you, and one she'll have inherited from her father. And when we do genetics for von Willebrand factor, we will look at both of the genes. So the report should come back with a description of each one of the genes. So either it says everything's normal, no mutation has found, or it says we have found a mutation on one of the genes and the other gene is normal. Or sometimes it says we have found two different mutations, one mutation on each of the genes, for example. And that way she's inherited something from both of you. But what sometimes happens is, not infrequently, it quite often happens, so this may well be what's happened, is they will have known your mutation, and so potentially look for the same specific mutation in your daughter. And then the report will be that she's inherited the family mutation in one of her genes. So you know that she's inherited your mutation, but then it will go on to do a description of the mutation. And that depends how it's been reported to the genetics database that's international. And I think because the von Willebrand disease is challenging to diagnose, there are mutations that have been described as causing more than one subtype of von Willebrand disease. So as in someone's been diagnosed with type 2M somewhere with your mutation and it's been registered, someone else has been diagnosed with type 1, but they also have the mutation, it's been diagnosed and it's been registered. And so sometimes it says a mutation is associated with both type 1 and type 2. And you go, yeah, that wasn't very useful, but at least you have the genetic mutation in the family, and your local clinicians can say, actually, we're confident that in you, it is this type of von Willebrand disease. I mean, the main bit is diagnosing the correct type of von Willebrand disease. There's a bit of me that thinks the main bit is just diagnosing von Willebrand disease. Like, that is the biggest challenge. And if you once have a diagnosis of von Willebrand disease, you are likely to get the right treatment. The risk is desmopressin if you've got type 2 von Willebrand disease, and that you won't quite get the correct genetic counselling if you're pregnant or for the wider family screening. But it's almost the most important thing is being diagnosed with a type of von Willebrand disease.
And would you agree that the phenotype always corresponds with the genotype? So are we generally looking that if it's type 1, it is going to be quite mild, and if it's type 2, it's going to be more significant?
So it is likely that, so kind of yes, as in it's likely that the phenotype within the family stays the same. But there are people with severe type 1 who have levels of 5%. So it is inherited that way. So the one that's the least strongly inherited is mild type 1 von Willebrand disease, because there are so many, there can be multiple genetic factors and other things, including blood group, that affect your von Willebrand disease levels. There can be fluctuation even if you have identified a mutation. Whereas type 2 von Willebrand disease, severe type 1 von Willebrand disease, type 3 if you end up getting it, but because you need 2 genes for that, the inheritance for other family members is a bit different. But yeah, for the type 2 and the severe type 1s, if you pass it on to your children, they should be affected in a similar way to how you are yourself. It shouldn't get much less or much more severe. There will be individual variations, but it's a good rule of thumb.
Thank you.
Thank you very much. So maybe I can advertise next session, seeing if new questions pop up. So it will be on the 11th of July. We are going to talk about treating von Willebrand disease. What are the options? And with us, there will be the duo, so physician and patient representative, Sophie Susen and Cathy Verbraeken. Sorry for the mispronounce always the name and surname.
Okay, there are no other questions for the moment.
If you want a question, I can pose another one. So we
Go for it, Joe.
okay. So Susie, we have some people, some patients who approach us sometimes, and they say that within the one family that there are different diagnoses. So there are some people, there may be a type 2 diagnosis of one sibling and a type 1 diagnosis in another sibling. And yet the bleeding severity can be exactly the same. So is this a misdiagnosis, or is this that they have inherited one gene from each parent, and so therefore, how is that working?
Who knows? So I think it could be either one of those. So, I mean, it does happen, like, and, you know, people inherit different genes, and, you know, maybe the parents are less affected because of the other balance of things. And so the children might have inherited something different from each of their parents, or one child has inherited 2 genetic mutations and the other child has only inherited 1. But I guess one would want to check everything about that family very carefully. So it's probably easier if they're in the same, if they're reviewed in the same specialist center compared to if they're in very different specialist centers. And I guess you would ideally want them all reviewed in the same specialist center, do all the different blood tests that I kind of highlighted about the different things you can do, including multimers and things like that, and do the genetics, and then work it out. But because that's interesting, right? And that's probably interesting both clinically and for the family. But it's good that all the children are under a specialist center, I suppose. But it is, yeah, it is probably one of those 2 things.
So it's just as complicated as we imagine.
Yeah.
If we have time, I can ask one question.
Go for it.
Okay. Doctors usually say that von Willebrand patients type 3, it's better to go on prophylaxis, as far as I know. Von Willebrand type 2, how you put them in prophylaxis from the pheno, from what they say, from what each person have? Is there any test, something you can make in order to put him?
Yeah. Okay. So good question. So type 3 von Willebrand disease, people with type 3 von Willebrand disease haven't always been on prophylaxis, and the prophylaxis for people with type 3 has fallen behind prophylaxis for people with severe haemophilia, so kind of the equivalent. And it's, I think, because it was thought for many years that although they may not have a detectable von Willebrand factor, the factor 8 is kind of often like 2%, and it's just enough to stop like recurrent bleeding. But actually we know now that if that people over time can get significant joint and muscle bleeds, or very heavy periods, and quality of life is important. So there's much more of a drive now to try and get people with type 3 von Willebrand disease on prophylaxis than I think there was, for example, 10 years ago. So even within type 3 von Willebrand disease, not everyone currently is on prophylaxis, but certainly clinicians should be having that conversation with everyone. It might be by the time you have an adult who very rarely bleeds, they make the decision not to go on to regular intravenous prophylaxis a couple of times a week, but that should very much be discussed. For type 2 von Willebrand disease, personally, I don't have anyone who is on prophylaxis. But what I would consider prophylaxis if someone had recurrent bleeding. So it's not normally the levels for someone with type 2 von Willebrand disease, although it can be low, it's high enough to stop bleeding except through more major trauma, for example. But if you have a patient who's got low levels and is having recurrent bleeding, then one should consider prophylaxis, whether it's type 2 as opposed to type 3. And it will be a balance of the type of bleeding that person is having and the potential risk for that over time, and whether, you know, following all of that discussion, someone is happy to have the intravenous injections, because it's still quite a big treatment burden for von Willebrand disease. But it might be, depending what the bleeding is, that someone has it temporarily as well rather than lifelong. So for example, I don't know, if someone has inflammation of their gut and starts bleeding from their gut, and there is a treatment that should be able to settle it down, as in a general treatment that should be able to settle it down, you might start prophylaxis for 2-3 months until another treatment has kicked in, and that's possibly more common. But yeah, I would definitely consider it, and it would be based on the symptoms that someone's having.
Thank you.
Thank you very much. So if there are no other common on question, maybe we can close the session. And I really want to thanks a lot, as usual, the speakers with us, because I'm so grateful that they share their time and the expertise and also biographical experience when it comes to patient representatives. So thank you very much. It's so important for us. And I also want to thank my colleague Daria for engaging in this project, and the EHC for the trust in the ERN in building this project together. So thank you very much.
Thank you, Mariangela. Thank you for providing this opportunity for the patients community to sit together with clinicians and discuss these very topical questions. And we really appreciate this, and thank you personally from my side. Thank you so much.
Thank you. Have a nice evening. Bye-bye.
Have a nice evening. Thank you.
Bye.
Bye.